thyroid nodular diseases, and thyroid carcinoma. Goiter refers to an enlarged thyroid gland. Different mechanisms can lead to the development of goiter, such as biosynthetic defects, iodine deficiency, autoimmune disease, and nodular diseases. Biosynthetic defects and iodine deficiency are associated with reduced efficiency of the thyroid hormone synthesis, leading to increased thyroid-stimulating hormone, which stimulates the thyroid growth as a compensatory mechanism to overcome the block in hormone synthesis. When diffuse enlargement of the thyroid occurs in the absence of nodules and hyperthyroidism, it is referred to as diffuse non-toxic goiter. This is sometimes called simple goiter because of the absence of nodules, or colloid goiter because of the presence of uniform follicles that are filled with colloid. Worldwide, diffuse goiter is most commonly caused by iodine deficiency and is termed endemic goiter when it affects more than 5% of the population. In non-endemic regions, sporadic goiter occurs and the cause is usually unknown. Thyroid enlargement in teenagers is sometimes referred to as juvenile goiter. In general, goiter is more common in women than men, probably because of the greater prevalence of underlying autoimmune disease and the increased iodine demands associated with pregnancy. If thyroid function is preserved, most goiters are asymptomatic. Examination of a diffuse goiter reveals symmetrically enlarged, non-tender, generally soft gland without palpable nodules. Goiter is defined somewhat arbitrarily as a lateral lobe with a volume greater than the thumb of the individual being examined. If the thyroid is markedly enlarged, it can cause tracheal or esophageal compression, though these features are unusual in the absence of nodular disease and fibrosis. Substernal goiter may obstruct the thoracic inlet. Pemberton sign refers to facial and neck congestion due to jugular venous obstruction when the arms are raised above the head, a maneuver that draws the thyroid into the thoracic inlet. Thyroid function tests should be performed in all patients with goiter to determine the functionality of the thyroid. TPO antibodies may be useful to identify patients at increased risk of autoimmune thyroid diseases. For most of the time, thyroid scanning is not necessary, but it will reveal increased uptake in iodine deficiency and in most cases of dysharmonogenesis. Thyroid ultrasound is very useful, especially if there is suspicious nodules on physical examination. Thyroid nodules are characterized by the disordered growth of thyroid cells, often combined with the gradual development of fibrosis. Nodular thyroid disease is common, occurring in about 3 to 7% of adults when assessed by physical examination. Using ultrasound, nodules are present in up to 50% of adults, with the majority being less than 1 cm in diameter. Thyroid nodules may be solitary or multiple, and they may be functional or non-functional, benign or malignant. Depending on the population studied, multinodular goiter, or the presence of nodules in a thyroid of normal size, can occur in up to 12% of adults. Multinodular goiter is more common in women than in men and increases in prevalence with age. It is more common in iodine-deficient regions but also occurs in regions of iodine sufficiency, reflecting multiple genetic, autoimmune, and environmental influences on the pathogenesis. Most patients with non-toxic multinodular goiter are asymptomatic and euthyroid. It typically develops over many years and is detected on routine physical examination when an individual notices an enlargement in the neck or as an incidental finding on imaging. If the goiter is large enough, it can ultimately lead to compressive symptoms, including difficulty of swallowing, respiratory distress, or phlegethora, although these symptoms are uncommon. Toxic multinodular goiter is almost similar to non-toxic multinodular goiter except for the major difference, which is the presence of functional autonomy in toxic multinodular goiter. In addition to features of goiter, The clinical presentation includes subclinical or mild overt hyperthyroidism. The patient is usually elderly and may present with atrial fibrillation or palpitations, tachycardia, nervousness, tremors, or weight loss. The TSH level is low and the uncombined T4 level may be normal or minimally increased. Thyroid scan shows heterogeneous uptake with multiple regions of increased and decreased uptake. Prior to the definitive treatment of the hyperthyroidism, ultrasound imaging should be performed to assess the presence of discrete nodules corresponding to areas of decreased uptake. If present, fine needle aspiration may be indicated based on sonographic patterns and size cutoffs. The cytology results, if indeterminate or suspicious, may direct the therapy to surgery. Radioiodine is generally the treatment of choice. It treats areas of autonomy as well as decreasing the mass of the goiter by ablating the functional nodules. Sometimes, however, a degree of autonomy may persist, presumably because multiple autonomous regions may emerge after others are treated, and further radioiodine treatment may be necessary. Anti-thyroid drugs normalize the thyroid function and are particularly useful in the elderly or ill patients with limited lifespan. In contrast to Graves' disease, spontaneous remission does not occur and so treatment is long-term. Surgery provides definitive treatment of underlying thyrotoxicosis as well as goiter. Patients should be rendered euthyroid using an anti-thyroid drug before operation. Toxic adenoma is the presence of a solitary autonomously functioning thyroid nodule. The thyrotoxicosis is usually mild and is generally only detected when a nodule is more than 3 cm. The disorder is suggested by a subnormal TSH level, the presence of thyroid nodule often large enough to be palpable, and the absence of clinical features suggestive of Graves' disease or other causes of thyrotoxicosis. A thyroid scan provides a definitive diagnostic test demonstrating focal uptake in the hyperfunctioning nodule and diminished uptake in the remainder of the gland as activity of the normal thyroid is suppressed. Radioactive ablation is usually the treatment of choice for toxic adenoma. Surgical resection is also effective and is usually limited to enucleation of the adenoma or lobectomy. Medical therapy using anti-thyroid drugs and beta blockers can normalize the thyroid function but is not an optimal long-term treatment. Apart from determining the functionality of nodules, there is a need to determine the risk of malignancy. Though thyroid nodules are quite common, less than 3% are actually malignant. Because many nodules are deeply embedded in thyroid tissue or reside in posterior or substernal location, it is not possible to palpate all nodules. Ultrasonography can be used to identify which nodule should be biopsied based on a combination of size and sonographic features that is associated with thyroid cancer. For nodules with more suspicious sonographic patterns, such as hypoechoic nodules with infiltrative borders, biopsy is recommended at a lower size cutoff than those with less suspicious imaging features. Thyroid carcinoma is the most common malignancy of the endocrine system. Malignant tumors derived from the follicular epithelium are classified according to histologic features. The following are the risk factors for thyroid carcinoma. Thyroid carcinoma are generally classified as to well-differentiated and poorly differentiated thyroid carcinoma. Differentiated tumors such as papillary thyroid cancer and follicular thyroid cancer are often curable and the prognosis is good for patients identified with early-stage disease. In contrast, anaplastic thyroid cancer is aggressive and responds poorly to treatment and is associated with poor prognosis. Papillary thyroid carcinoma is the most common type of thyroid cancer, accounting for 80 to 85% of well-differentiated thyroid malignancies. Characteristic cytologic features help make the diagnosis by fine needle aspiration or after surgical resection. These include the presence of a large, clear nuclei with powdery chromatin described as an orphan Annie eye appearance, with nuclear grooves and prominent nucleoli. Papillary thyroid carcinoma may be multifocal and invade locally within the thyroid gland, as well as through the thyroid capsule and into the adjacent structures in the neck. It has a propensity to spread via the lymphatic system but can metastasize hematogenously as well, particularly to the bone and lungs. Most papillary cancers are identified in the early stages and have an excellent prognosis with survival curves similar to expected survival. Mortality is markedly increased in stage 4 disease, especially in the presence of distant metastases, but this group comprises only about 1% of patients. The incidence of follicular thyroid carcinoma varies widely in different parts of the world. It is more common in iodine-deficient regions. Currently, it accounts for only about 5% of all thyroid cancer diagnosed in the United States. Follicular thyroid carcinoma is difficult to diagnose by fine needle aspiration because the distinction between benign and malignant follicular neoplasm require histology because the nuclear features of follicular adenomas and carcinomas do not differ. Rather, follicular carcinoma is diagnosed by the presence of capsular or vascular invasion. It tends to spread hematogenously, leading to bone, lung, and central nervous system metastases. Mortality rates associated with angioinvasive follicular thyroid carcinoma are less favorable than for papillary thyroid carcinoma, in part because a larger proportion of patients present with stage 4 disease. Poor prognostic features associated with follicular thyroid carcinoma include the presence of distant metastases, age more than 50 years at diagnosis, the primary size of tumor more than 4 cm, Hürthle cell histology, and the presence of marked vascular invasion. For thyroid carcinoma treatment, in addition for removing the primary lesion, surgery allows accurate histologic diagnosis and staging. For patients at high risk for recurrence, bilateral surgery allows administration of radioiodine for remnant ablation and potential treatment of iodine-avid metastases, as well as for monitoring of serum thyroglobulin levels. Therefore, near-total thyroidectomy or total thyroidectomy is appropriate for tumors more than 4 cm or in the presence of metastases or clinical evidence of extrathyroidal invasion. Preoperative sonography should be performed in all patients to assess the central and lateral cervical lymph node compartments for suspicious adenopathy, which if present should undergo fine needle aspiration and be removed as indicated at surgery. After near-total thyroidectomy or even total thyroidectomy, less than 1 gram of thyroid tissue may remain in the thyroid bed. Post-surgical radioablation of the remnant thyroid eliminates residual normal thyroid, facilitating the use of thyroglobulin determinations. Levothyroxine suppression of TSH is a mainstay of thyroid cancer treatment. Although TSH suppression clearly provides therapeutic benefit, there are no prospective studies that define the optimal level of TSH suppression. The degree of TSH suppression should be individualized based on a patient's risk of recurrence. It should be adjusted over time as surveillance blood tests and imaging confirm the absence of disease or alternatively indicate the possible residual or recurrent cancer. For patients at low risk of recurrence, TSH should be maintained in the lower limit of normal. For patients either at intermediate or high risk of recurrence, the TSH level should be kept to 0.1 to 0.5 and less than 0.1 respectively. If there are no strong contraindication to mild thyrotoxicosis, TSH should be less than 0.1 milli-IU per liter for those with known metastatic disease. A whole body scanning following radioiodine treatment is used to confirm the iodine 131 uptake in the remnant and to identify possible metastatic disease. For follow-up, serum thyroglobulin is a sensitive marker of residual or recurrent thyroid cancer after ablation of the residual post-surgical thyroid tissue. Because the vast majority of papillary thyroid cancer recurrences are in cervical lymph node, a neck ultrasound should be performed about 6 months after thyroid ablation. Ultrasound has been shown to be more sensitive than whole-body scan in this scenario. Anaplastic thyroid carcinoma is a poorly differentiated and aggressive cancer. The prognosis is poor and most patients die within 6 months of diagnosis. Because of the undifferentiated state of these tumors, the uptake of radioiodine is usually negligible, but it can be used therapeutically if there is residual uptake. Chemotherapy has been attempted with multiple agents, but it is usually ineffective. External beam radiation therapy can be attempted and continued if tumors are responsive. Medullary thyroid carcinoma can be sporadic or familial and accounts for about 5% of thyroid cancers. There are 3 familial forms of medullary thyroid carcinoma: multiple endocrine neoplasia 2A, 2B, and the familial medullary thyroid carcinoma without other features of multiple endocrine neoplasia. In general, the medullary thyroid carcinoma is more aggressive in multiple endocrine neoplasia 2B than in 2A, and familial medullary thyroid carcinoma is more aggressive than sporadic medullary thyroid carcinoma. Elevated serum calcitonin provides a marker of residual or recurrent disease. All patients should be tested for RET mutations because genetic counseling and testing of family members can be offered to those individuals who test positive for mutations. The management of medullary thyroid carcinoma is primarily surgical. Prior to surgery, pheochromocytoma should be excluded in all patients with a RET mutation. Unlike tumors derived from the thyroid follicular cells, these tumors do not take up radioiodine. External radiation treatment and targeted kinase inhibitors may provide palliation in patients with advanced disease. Lymphoma in the thyroid gland often arises in the background of Hashimoto's thyroiditis. A rapidly expanding thyroid mass suggests the possibility of this diagnosis. Diffuse large cell lymphoma is the most common type in the thyroid. Biopsies reveal sheets of lymphoid cells that can be difficult to distinguish from small cell lung CA. These tumors are highly sensitive to external radiation. Surgical resection should be avoided as initial therapy because it may spread the disease that is otherwise localized to the thyroid. If staging indicates that the disease is outside of the thyroid, treatment should follow the guidelines used for other forms of lymphoma.